So good afternoon, everybody. We will be recording this training like we did last week. And we're very happy to see all of you this afternoon.
Yeah, happy to see you.
Oh, good. Yes, it's very cool that we can be far geographically, but we can be close in the spirit. We know that the Holy Spirit is everywhere, and we are just as close to God here as you are there. And we could be close to each other virtually. So it's very cool. And again, I think I've started each teaching just by sharing that my experience is here in Canada, and I have different resources than you do. And so I will be sharing the information that I've got from the African Palliative Care Association, but we will need to, you'll need to modify and adapt to your context according to the medications and the resources that you have. So again, during our teaching time this morning, I'm hoping that I can also learn from you. So yeah, I think you also know that I worked in Senegal for many years, and most recently I worked with a home care team that was doing palliative care in the city of Dakar. And then I've also been involved in just teaching with an organization called PalChase, and that is mostly in Kenya, Sudan, and a lot of countries in East Africa. So we'll move on to our topic for today, which is going to be about symptom management. So we know we've been talking about palliative care, and we've had definitions of palliative care as chronic disease or disease that is life-limiting. And so today we want to talk a little bit more about symptom management. And I know that one thing that's difficult maybe in your context is that sometimes you don't see people until it's quite late in their disease. And so hopefully this presentation will help, and hopefully I can learn from you as well. So again, I'm using materials from PalChase. Oops, sorry. Go to the next one. And this is in accordance with the African Palliative Care Association. And I will share the PowerPoints and the presentation just like we did in the last. So today we're hoping to talk about, we're on the fourth module. So we've talked about, we've introduced ourselves to palliative care. We've talked about effective communication. And then last week we talked about pain assessment. One thing that I'm hoping that we're all really understanding is how different each individual is, and how we really need to have empathy, and we need to be able to try to understand ourselves and understand other people, and recognize that different people have require different kinds of approaches. And I think that was one thing that I appreciate about your challenges is how you have a lot of different ethnic groups, and some of them are quite challenging. And I really appreciate how you're trying to learn to communicate and work with people who come from cultures that are quite different. So today we're going to talk about some of the common symptoms that people struggle with when they're getting closer to the end of their life. So these are going to be dyspnea, so shortness of breath, nausea and vomiting, anxiety, and agitation. Yeah. So we're going to start off with dyspnea. I'm wondering, before I go to the next slide, if somebody could explain to me what dyspnea is. Does anybody feel like saying what they think dyspnea is?
Supposed to pronounce it very well. Dyspnea.
You what?
Here?
Okay.
Which one?
That's
am
the
I-
next one.
Okay.
So don't read that one if you're not showing it to them. That's the one that they see.
Does anybody have an idea?
Yes, someone has an
It
idea.
means difficulty in breathing.
Sorry, I didn't quite.
Difficulty in breathing.
Okay, so it's having a difficulty breathing, right? So one of the exercises, so you're right, dyspnea is having a hard time breathing, shortness of breath. But one thing that's important to remember about dyspnea is there's also a subjective element to dyspnea. So one of the exercises that I had in my when I was doing some training was to breathe through a straw. So do you have straws there?
Come again, pardon?
A straw. So you know the straw that you suck out of when you're drinking something?
Okay, okay.
Yeah.
Yes.
So if you take a straw and you breathe through the straw and you only breathe through the straw, and until I tell you, you can start breathing again, you start feeling a little bit panicky because you're not able to get all the air that you need, right? And this is often what people feel like when they're going through dyspnea. There's a real element of a panicky feeling that I can't get the air that I need. Yeah, I'd encourage you to try it. So some of the common causes of dyspnea, it's not going to the next one. Some of the common causes of dyspnea. So, you know, often we have tumor involvement. So people who have lung cancer, the lungs are not working as effectively anymore. There may be an infection like pneumonia, or the lung function's not working, or the heart, the muscles are weak, pleural effusion, ascites, anemia, and anxiety. These are all things that can cause dyspnea when we're looking at palliative care. So I'm just wondering, what are non-pharmacological ways that we can manage dyspnea? What can we do if we don't, for example, have medications? How can we help people when they're experiencing shortness of breath? Do you have any ideas?
I said positioning the individual.
Okay, for sure. So changing position. Anything else?
Breathing inside a brown envelope.
Breathing in a brown envelope. So helping them with the breathing. Anything else?
I think you can also start intranasal oxygen with them and maybe start with some intranasal oxygen and then try to figure out where the cause of the of the difficulty should be.
Right, so you could give oxygen.
So how about chest physiotherapy, encouraging deep breathing exercise?
So
Also,
encouraging breathing, that's a really good one. How about if the person who's having a hard time breathing is in a room where everyone's freaking out because they're having a hard time breathing? Do you know what I mean? Like, what if everyone's like, oh, he can't breathe, he can't breathe, he can't breathe. Does that help?
No.
So making sure there's there's a quiet, calm atmosphere. Sometimes people can get short of breath just because the family's hovering around so much, so afraid and so anxious. It can really help to get a quiet atmosphere. Do you have fans in your like small fans in the hospital?
Yes, we do. Personal farms, yes, we have people who have personal farms in the hospital.
So sometimes just the airflow, a little bit of airflow in front of the person's mouth can help them as well. Feel like they're getting more air. So you've come up with very good ideas. And I think it's important because sometimes we might not have the medications to help people. So I was curious for the person who talked about physio, because I think the breathing exercises are really can really be helpful. And also the person who talked about the brown bag, that breathing, taking long breaths. So breathing in and then breathing out through pursed lips. So that means it looks like you're blowing out a candle. And sometimes it might be actually necessary to breathe with the person to show them how they're supposed to be breathing. And that can help as well. Sometimes having a little bit of a cold washcloth. And I think that this point here for education, I'm not sure if you have, do you have the oximeters in your hospital? Yeah, I find sometimes people, especially people who have diseases kind of like COPD or pulmonary fibrosis, where they have been monitoring their O2 sats and they're really used to checking what their O2 sats are. They can get really fixated on the numbers of those O2 sats. And sometimes I have to tell people to stop looking at those because it really, when we're working with this dyspnea, it's really more about how that person is feeling subjectively than about the objective numbers. So, so I will sometimes tell people, I had a man actually the other day, his wife is in our hospice, and he came up to me and he said, I would really like you to take her vital signs and her O2 sats every day and tell me what they are. And I said, well, why are you asking me to do that? And he said, it's because I want to know how she's progressing. I want to know, how close, if she's getting closer to the end. And I said to him, really, it's not about the numbers, because our focus here is on comfort and it's about how she's feeling. So we're not going to take the vital signs. We're not going to take the O2 sats because we're going to deal with her, how she's feeling. So if she's feeling like she's short of breath and she needs oxygen, we'll give her some oxygen, or we'll use the fan, or we'll do the things that we talked about. But we're not doing treatment anymore. We're looking at comfort. So I don't know if that's something that people there also love, is getting their O2 sats checked. But when somebody's getting closer to the end, it's not always that helpful. There are pharmacological things. So again, I know we talked about morphine last week, and I think you only have the 10 milligram vials, right? Is what you said? You only have the 10 milligram vials in your pharmacy or in your hospital?
Yes, 10 milligram.
Okay. So the thing is, it's because you don't have, so just so you know, in the future, that low doses of morphine, low doses of opioids are very, very helpful when people have dyspnea. what it does is it doesn't stop the problem, but it stops them, it blocks something in the brain so they don't feel that air hunger feeling. And so often when we have patients who come in and that's one of their primary symptoms, we do put them on a low dose of an opioid like morphine. And that can be very, very helpful. So this is the pharmacologic right here. So the first line would be very low dose of morphine. Do you use morphine for shortness of breath in EGB?
No.
No. Okay. So I understand, because if you don't have the smaller doses and it's not that easy to access, this would be like if you have the oral doses, if you had the syrup where you could give a very small dose of the syrup, that would really help calm that person's symptoms of dyspnea. So it's just, yeah, it's too bad. You can also use codeine. I don't know, do you have codeine?
Yes.
And I know you have tramadol. So again, I'm sorry, I don't know tramadol very well. So I don't know, can tramadol be used for shortness of breath?
No.
No, okay. What about your pentazocine? I don't know that drug either. That one's probably not used for it either. So do you have Ativan?
No.
Yeah.
Please come again.
Do you have Ativan?
No.
No, okay. So what would you use if somebody's feeling extremely anxious because they can't get their air?
Most times we give we reassure and give diazepam.
Diazepam. Okay. So would you have the diazepam tablets?
Yes.
Oh, okay. So most of the time you would give them a diazepam tablet and then that would calm them down?
We use IV.
Oh, you use the IV. Okay. 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 So what if, okay, so you give the IV Ativan if somebody is struggling with their breathing? So what kind of a how do you think a person like a chaplain could help in a situation with dyspnea?
In most cases, we place them on oxygen or we position.
Okay, so you place them on oxygen and you reposition them. But if they're feeling super anxious, we know that this whole there's a little bit of a circle that happens when somebody is struggling with shortness of breath. They get really anxious, and then the anxiety makes them more shorter of breath, and then it's just kind of over and over. So it's really important to actually address the anxiety as well. So this is where I think somebody who's a chaplain, especially if you're working with people who are people of faith, prayer could help. It's not like it's going to take it away, but you need to break that anxiety cycle, because that anxiety cycle will just increase their problems with their breathing. So I think not to minimize the importance of also a team approach when we're dealing with palliative patients, and that we need everybody. We need people who can come and sit with the people so they don't feel alone. We need chaplains who can come and give comfort and give peace and pray to help people not be as anxious. And then, of course, we do need the pharmaceutical things as well. But those are usually, as we have talked in the past, it's usually the nurses, it's usually the doctors prescribing and the nurses that are giving these medications. But you probably are very busy and you might not have 5, 10, or 15 minutes to sit beside somebody and just be with them and pray with them and maybe breathe with them if they need somebody to help them with the breathing. So I think it's really important to recognize this team approach and the importance of including other people. If you see somebody who is really, really struggling with shortness of breath and anxiety. So the next common symptom that we want to talk about is nausea. So often people will have nausea. And one of the important things to know about nausea, which is, I think I've said before, one of the things that I like about palliative care is palliative care, being in palliative care, it's being a little bit like being a detective. So when you see nausea or you see vomiting, it's important to ask the question, why could this person be nauseated? Would we expect this person to be nauseated with the illness that they have? What could it be that could be causing somebody to feel nauseated? And the reason this is important is because there's different mechanisms that cause people to be nauseated. So these are kind of busy slides, but you'll have these slides to look at later. So this one here shows you how there's different parts in the brain that that are different mechanisms. So for example, you see the vestibular apparatus, that's motion sickness. So that's part of the brain, that's making a person feel nauseated. And for each one of these areas, there's a different medication. So why it's important to know this is if you think, and I know I used to think that, and I don't even see that you have it there, but in Canada, we have something called gravel, which is diamond hydronate. And I used to think that anytime somebody was nauseated, they needed that. But actually, diamond hydronate is a medication, an antiemetic that works on motion sickness. So it's really good for somebody who is having those issues because of that, but it doesn't really work for people who are having nausea, for example, because of their chemo or something like that. The other thing is, I think we've talked about it in the past, that nausea could also be from constipation. So that's a really important thing to know too. If people haven't gone to the bathroom, then for a certain number of days, then they can feel nauseated because the stomach needs to empty. So there's a lot of different reasons why people could feel. Here we also see that there's fear, pain, sights, smells, anticipation. So it's important for us to do an assessment to find out why this person might be feeling nauseated. And then when we do our management of our nausea, we have to look at the correct cause. So if somebody is constipated, then that we're going to help them go to the bathroom. If it's the environment, then we're going to try to work on that. So again, a calm environment, using a cool cloth, giving somebody who has, like if somebody comes in and they have pretty constant nausea, it's better to give them something regularly than to just wait until they have the nausea. We know that if people are struggling with nausea, often they're afraid to eat or drink. And we also know that dehydration can cause people to become nauseated. So we just want to make sure that we're covering all of our bases. And we want to make sure that we are treating the causes of the nausea. So I'm just curious again, how have you seen people in your context treat nausea? Because I know in different countries they have different things that you can treat nausea with that are not prescription drugs. So I'm just curious, for a few minutes, just talk to the person next to you. How have you seen people in your context treat nausea without prescription drugs?
So now,
Okay, so can I hear some of your answers?
From each of the groups. Okay, so without drugs, I think you can. For me personally, I tell them to use candy, like candies. I think
Candies?
some yes, yes, candies. Yes, I think also yes. So, I think some people here also say lemon, some lemon or ginger. Ginger.
Okay. So you said ginger and lemon and candies?
Yes. Okay. Lime water.
Somebody said lime water. Making
Lime
use of
water.
lime.
Okay.
Another thing is sprinkling water on on that person's face.
Prickly water?
Water, yes.
So is it a plant?
No, it's sprinkle water.
Water, like two. Then another thing is to find that fellow.
Sorry, I missed that one.
Then yes, and expose the person to air by opening of nearby windows, removing excessive clothing and others.
Okay, so just helping them feel more comfortable.
Yes.
Okay. Anybody else? So we got these ones. Like you said, changing the diet. Do you have a diet that you recommend for people who are having nausea?
Yes, pepper, food with so much pepper.
Pepe. What's Pepe?
Pepperish food. Food with pepper spice.
Pepper spice. Does the pepper spice not make people more nauseated? No, it actually helps. Do you have do the people there grow ginger? So you can actually get ginger in your market? Okay. Yeah. Okay, so you've come up with some good ones in case people now I'm just curious about are there not any kinds of leaves that people would make a tea out of some kind of leaf? I guess not. And then I think it makes sense. We also talked about to stop irritating medications like NSAIDs. And I think what I learned from you last week was a lot of people do have gastric issues because of their spicy jollof rice. Is that what it is? And so just maybe stopping some of the foods that would be irritating the stomach. I don't think I ate rice when I was in Egby. So, so I don't know if you just have like a bland, I know that here people would say just drinking like a bland broth might help if you're feeling nauseated. So, but I didn't see a lot of chickens in Egby either. But a chicken. So here we also just a reminder that when we're managing vomiting, the treatment needs to be mechanism based, not generalized. So like I mentioned, we need to make sure that we're doing an assessment and we're not making assumptions that we know why this person is vomiting. And then, as I mentioned, this is the reason why, because there's different mechanisms that cause people to feel nauseated. So like the one in the yellow circle, often what's happening in those ones is the person's stomach is not emptying as quickly as it should. And so that's part of the reason why they're feeling nauseated. So they need a medication that will actually help them to digest their food more quickly. And so it's important for us to understand why people are feeling nauseated. And then this is a really busy slide, but it shows you both together. So it shows the different types of medications that can be used for those receptors. And I think if you do have people that you're starting on morphine, that's another important thing to know, that morphine, one of the side effects of morphine can be nausea. The nausea will usually go away, but it can stop people from wanting to continue on with their with taking morphine because it makes them feel so lousy. So it's a good idea if you're starting somebody on morphine to start them on an antiemetic at the same time, and to start them on an antiemetic that is like that, the yellow circle there, because what happens when people are taking morphine is it actually does slow down the digestion and it slows things down. So they need a medication that will help them. And I think you have, I think I saw that you have ondansetron, and you also have medical bromide there. So here we've got, yeah, you've got those, don't you? So you do have medical bromide. Yes? Okay,
Yes.
all right. And you have it in tablets as well as IV? Okay. Okay. And so these are just things to remember. So we want to avoid that in a bowel obstruction. So this is why if somebody is feeling nauseated and we're trying to figure out how to help them, we want to make sure that we do a good assessment for bowels to find out, is it possible that this person is constipated and that's causing their nausea? Because if they haven't gone to the bathroom for like 10 days, and they're at risk for a bowel obstruction, and you give them a medication that's going to speed things up, then you're just going to cause more problems. So it's important to do that assessment. I think that you also have this one. Do you have domperidone? You can look at this after. Do you have, do you have, I think you do have Haldol. I saw that in the list. How common is using Haldol for nausea there? Do you use it for nausea? Just wondering if do you use the Haldol at all for nausea there? Okay, well, in our where I work, this is our number one go-to for nausea. If somebody is having nausea and vomiting, we will give them a subcutaneous injection of 1 milligram of Haldol, which usually works really well. So so Haldol is actually not a bad drug for nausea. What we will do as well is if somebody is struggling with kind of constant nausea and vomiting, we'll put them on a regular Haldol schedule. So often we'll give them, sometimes you see it's BID or TID, it really depends on the person. But Haldol is actually a really good drug for nausea and vomiting. And you can give it sub-Q. So it's very easy. You can also get the tablets, and the tablets are usually really small. I don't know if you have the tablets there. But Haldol is a really good drug for nausea and vomiting. And then I know that you also have, I think you have olanzapine as well, which is also good for anxiety, that people are feeling anxious because of nausea. So I think as we're talking about each symptom, I think you can see how things tie in and how we need to make sure that we're always also having a holistic approach and recognizing that when people are struggling with some of these symptoms, there's also going to be anxiety or isolation. There's going to be social, there's going to be psychological, there's going to be spiritual things that they're struggling with. So even if you're not a doctor or a nurse, you can still help. You might not be able to give the medications, but your presence and your prayers, or you're listening if they can talk, can really help with some of these symptoms. So the next symptom we're going to talk about, which is also super common, is constipation. So again, maybe take a couple minutes with your partner and talk about how would you define constipation? And what are some of the risks associated with constipation? I'll just give you a couple minutes. What would you say is constipation? How do you know? Are you ready? Oh. I can't really hear you.
I'll just,
Hello, I can't hear your microphone.
things on.
No, I can't hear you. What?
What would help is if he was there and could WhatsApp him. Or like,
Can you hear me? Can you Can you put your hands up if you hear me? Oh, okay. Because I can't hear you. So maybe I'll just keep going. Sorry, that way we're not just sitting here because I can't hear anything. Oh, okay, now
Can
yeah, you're back. I can hear you. Okay, do you have something to share with me?
Yes, we said constipation is when someone passes less than 3 stools in a week.
Okay, less than 3 stools in a week. Okay,
Hard stool
okay, hard stools
associated with pain.
associated with pain. Okay,
That is definition of constipation.
okay, okay,
And associated risk,
okay,
discomfort, pain.
Mhm.
It's constipation is associated with a lot of discomfort and pain,
okay,
and it can affect the breathing too in the course of straining.
right,
So it
Yeah.
can affect breathing.
okay. Thank you. So you said 3 stool in a week, 3 hard stool in a week.
I want to say maybe blood in the rectum.
Okay, you can sometimes have blood in the rectum. Do people there have problem with hemorrhoids? Or I don't know, do you call them piles?
Another associated risk can be fecal infarction. Can you hear me?
Yes, fecal impaction. So can you describe what fecal impaction is?
That's when the has to block the anal canal
Mm-hmm,
and prevent even the other liquid tube that is up or in the proximal part to come out.
mm-hmm,
Usually it can also lead to leakages.
mm-hmm,
The time of the liquid one trying to find itself to come out bypassing the impulsion.
mm-hmm. Yeah, and that is really important to know because often those kinds of people have that liquid stool, and so they think they have diarrhea, right? And so one way that we like to explain that, it's also like you have a rock in the river. So you've got the river, that's your intestines and your poo. But if you've got a hard block of poo, the river has to go over and comes out and it's leaking. So the person is leaking poo. They may think, I'm not constipated because I'm going poo all the time. I see people like that. I don't know if you do. So those are really good. And we also talked about the fact that you can get an obstruction from constipation if you don't deal with it early enough. So it's really important not to allow people to go for 10 days without a stool. I don't know if you have a protocol in your hospital. We would say where I work that we want to see a stool every 2 or 3 days. And we have different protocols that we use if we don't see one. But I'm also just wondering about the way people eat there. Do people's diet make them prone to constipation?
Yeah, so we have some technical issues there.
Okay,
So yeah, welcome back.
okay. Are you ready for me to keep going?
Yes, we can keep going.
Okay, so we were on constipation. And we're gonna talk about, let's see, different ways to treat constipation.
Yeah, sorry.
So, so making sure that people drink enough. People don't realize often that just drinking enough water is really important. Having a high fiber diet. So that's what I was wondering. Do people get constipated, like in the villages? Like generally speaking, I know where we were working in Senegal, a lot of people had problems with constipation because they were mostly just eating rice and millet. Is this a problem for people in the villages? No? People don't really struggle with this?
Okay, they do.
They do have these problems?
Yes.
Okay. And how open to changing their diet are people? I mean, I know that in different cultures, food has a lot of meaning. So if you were to encourage somebody to try to increase fiber in their diet, what would that look like there?
Okay, so most of them do comply with the changes of their diet, most especially their diets.
So what would the changes be for the diet there in Egby specifically?
Mostly fruits, high fiber containing diets, drink more water, basically.
Okay, so do they have, I guess you do have quite a bit of fruit. So you do have mangoes. Um,
There's oranges, watermelon.
okay. And so,
A lot of
people will encourage, if you encourage them to increase in eating those things, they won't say they don't have money for it.
no, mostly they comply. They
Okay,
say that
okay, that's good. And then for in the hospital, if somebody does have a problem of constipation, how do you treat them in the hospital?
okay, we use some of the pharmacological treatments, like we do have liquid paraffin here. We have Bisacodu. We have both the suppository and tablets where we can
Okay.
use.
Okay. So do you have like a protocol for somebody who's constipated? So if they haven't gone to the bathroom for 2 or 3 days, then this is what you start with. And then if they don't, you move to this or you move to that. Do you have something like that?
Not really, but usually we do start with conservative management, like non-pharmacological. About tell them to change their dietary changes and
Okay.
watch to see if it does continue. But in some cases, if it's bad, we start the pharmacological therapy treatments.
Okay. So like the bisacodyl, would you do that first for a few days? And then if you don't see anything, then you would give a suppository?
Yes, or we can further do maybe a plain, yes, an enema, or maybe if it's still not working, we can do maybe an X-ray, plain abdominal X-ray.
Abdominal, sorry.
Abdominal X-ray,
Oh, an abdominal x-ray to see if there's a blockage?
yes, an
Oh,
obstruction.
okay. Okay, that's good. Okay, so then you can get you have those medications that you need for treating constipation.
Yes, we do.
Okay, that's good. Another thing just to remember is people who do start on morphine are going to have problems with constipation. That is a side effect of using an opioid that the body does not get used to. So it's really important to put people on a bowel regimen as soon as they get put on a morphine. I guess it depends on whether the person there is still eating or drinking. But it's important that we recognize. So if you're putting somebody on a morphine, that maybe they get put on the bisocodyl at the same time, so that you're preventing that constipation from happening. How do you have like, let's say somebody is not eating or drinking anymore. Is it still important for them to have a bowel movement?
No, no.
What do
Although
you,
sometimes, sorry?
sorry, what do they say there?
No, they usually don't have bowel movement. That's if they haven't been eating for maybe a long period of time or
Okay.
drinking.
Okay. Okay. So the thing is, it's hard because when people aren't eating or drinking anymore, it makes sense that they wouldn't be having a stool, but the stomach is always shedding. So they should still have a small stool every 3 days, even if they're not eating and drinking. That's where it depends on where the person is in their journey with their disease about whether or not you're going to want to do something for that constipation. So if I have a patient who's not eating or drinking, but I know that they're not that close to the end, that means that they may be for another week or 2 weeks, as much as I think from my judgment, then I may still use a suppository for somebody who's not able to tolerate things orally anymore, because people who are not eating and drinking can still have constipation, and often it would present themselves as agitation. So when you see somebody and they're restless and they can't tell you what's wrong anymore, and you're not sure if it's the pain, if it's anxiety, I want to make sure that it's not constipation. So even if a person's not eating or drinking, they should still, I don't know the number. I think what I learned is that it should be like a handful, and would be very, very soft, but they still should be passing something. So the next symptom that we're going to talk about is anxiety, because most people are anxious, especially when they don't know what's going on and their bodies are not, their bodies seem to be changing and they might not have control. I think often people get anxious because they don't know what's happening. I'm just wondering from your side there, if people, how do people express anxiety? Like your patients that come to Egby, how would you know by seeing someone if they're struggling with anxiety?
Their facial expression.
So they would show you on their face?
Some patients, you see, like the look on their face will not look good, will not be good.
Okay.
Some may be transparent of aggression,
Okay.
and then some they will ask you so many questions again and again, no matter how much you try to clarify.
Yeah. So you can tell they're very anxious because they keep asking you the same thing over and over again.
Exactly.
And so I'm imagining that if people don't really know what's going on, they're going to be quite anxious. These are some of the things for managing anxiety. And I'm not sure how does your hospital deal with anxiety? How do you manage anxiety? Like if you have somebody like that, what do you do?
Well, you just try to give as much information as you can, then try to calm the person, give reassurance. Yeah, but
And do you Do you sometimes ask the chaplain to go and visit these kinds of patients?
Well, a few times, yeah. We could ask the chaplain to visit the person for counsel and prayers.
Yeah. Yeah, like I said, it's hard because we think that, you know, we can do stuff as the head, as the medical team to help this person, but sometimes the quiet, the prayers and the counseling can help the most. I know you said you have diazepam, so do you give people diazepam for anxiety?
Well, maybe sometimes.
Yeah, sometimes. I didn't see on your list other medications that you may give for anxiety. So I'm not sure if you have any other resources in your hospital. Hang on, I'm just going to mute my. Sorry, it's the street cleaner. Do you have things like Seroquel or mirtazapine? No? So what would be the medications that you would use for anxiety?
Sometimes we do use diazepam in severe cases.
Okay.
We can sertraline, then tryptyline, and
Okay.
basically.
Okay. Okay, so you have those medications, so that's good. I'm not sure how much you would be practicing these kinds of complementary therapies. These usually take a lot more time. And they're kind of new. So I won't go over them right now. I think when we talk about our module on self-care, we might talk about some of these things a little bit. So I'll wait until we get there. But then when we're talking about chronic anxiety, you mentioned already that you have some SSRIs, and citalopram and sertraline is what you use there as well. Oh, sorry, my street cleaner is coming back again, so I'm just going to mute for a couple seconds.
It's complicated.
Okay. I just was going to mention that with anxiety again, there can be a real social aspect of anxiety. So that sometimes takes a little bit of researching or assessing, because sometimes it's the family that makes the patient more anxious. So I think that's an important thing to recognize. And I think probably in your context where people are struggling with having the resources, that some of those things could be causing anxiety as well. And I know I've told the story more than once about the man in India who didn't want his sons to end up being becoming fishermen like him, and his anxiety and pain was really all related to the future of his sons. So I think this is where it's important to recognize that we do really need to rely on counselors and chaplains to help to maybe figure out what some of the real anxiety issues might be, and to be able to talk about it. And this is also another real argument for starting palliative care early. I think when we were doing the introduction, and that we start palliative care at time of diagnosis, because research shows that if people have some kind of an understanding about what's happening to them, that it actually causes them to be less anxious. And last week we talked about pain and how, it's important if you can explain to somebody why they're having what they're having, then it might actually just calm them down a little bit. So I know this is hard when we're busy, but just to have that in our minds as well as asking the questions. For example, if the person is anxious, like what is making you the most anxious? Or what are the things that are bothering you the most? So that you could get a true picture of what it is. So next one we're going to talk about is delirium. So delirium is different from dementia in that delirium is something that kind of comes on suddenly. So with dementia, when someone has dementia, it's kind of like you see a gradual change in that person's condition. But when you see somebody who all of a sudden becomes confused, or not just confused, but also becomes a little bit more like maybe more quiet, this is a very common symptom that comes at the end of life. So it's important for us to recognize it as well. And there is actually an end of life delirium where people seem to get kind of like a last burst of energy or confusion, or I don't know if you've seen this where people they hallucinate and they see people, and sometimes it's really hard for families because they think that this person is going to get better because all of a sudden they seem to have this extra burst of energy. But that can be an end of life delirium. And I had somebody like that last week. So it just helped the family for us to explain that what we're seeing here is something that often does happen at end of life. And this is normal for people who are dying. So there's different kinds of delirium as well. And that's an important thing to know because sometimes we can miss the hypoactive delirium. So the hypoactive delirium is when the person actually is inactive. And the thing is, this one's actually easier to manage than the hyperactive one. It's often the hyperactive one that is just really, really difficult because that's when the person keeps trying to get out of bed and they're falling or they're pulling out their lines, or yeah, they're saying things that are inappropriate. And it can be really hard to find ways to manage that hyperactive delirium. But the hypoactive is just as serious, but it's just, we sometimes miss it because we don't have to worry about that patient's safety because they're just so quiet. And so then there's also mixed where a person can fluctuate between both of them. So we have for managing delirium, we also have non-pharmacologic and pharmacologic. So for non-pharmacology, it's making sure we have a quiet space. So again, I don't know how realistic that is in EGB. I don't know if it's if the wards, if that's the space where people usually are at the very end of life. And I don't know also, now that I'm thinking about it culturally, if it's what people would want here, it is what people would want is to be quiet. And just to have a calming atmosphere, repositioning people. Also here, we talked about ruling out urinary retention. Urinary tract infections can also cause delirium, especially in older people. And then I also mentioned that constipation can cause delirium. So it's really important when we're, again, like I mentioned, we're like little detectives trying to figure out what's going on and why is this person showing us these symptoms. So, we want to make sure that they've gone to the bathroom and that that's not why they're getting agitated and moving around in their beds. And then We use Haldol as well here in Canada. I'm not sure, what do you use in Egby for delirium?
Similar drugs. We use similar drugs. We also use antipsychotics.
Okay,
and
you have the similar, okay, yeah. Sorry,
in addition to Adol, we also have other antipsychotics like CPZ that is also used.
okay,
And in addition to lorazepam, we also have other benzodiazepines like nitrazepam, just as she's saying, and also bromazepam in that same family of benzodiazepines.
okay. Okay. And how often would you see delirium there? Is it common?
It's not so common.
It's not so common. Okay.
Maybe
So,
like 1 to 2 out of 10.
okay. So in the people that actually come and die in the hospital, is it more common in those people?
Well,
The people who actually die in the hospital?
okay, those who died in the hospital, you mean as a result of delirium?
Yeah, do they experience delirium before they die?
Well,
So, yeah, most of them do, yes, have delirium because there are quite a number of them, but not in all cases.
Okay, okay. And so it's also important to maybe discuss with the family, this is part of, it's not good, but this is part of what happens when people's bodies are getting ready to move on. So it's important for us to recognize when that's happening. Again, I'm going to make an assumption that people are not taking opioids that much. So they're probably not going to be getting delirium as a side effect from an opioid. Can people become delirium from tramadol?
Yes, yes.
Okay, so people can develop a delirium from taking tramadol.
Yes.
And then what would you do in that situation?
We try to maybe reduce the dose of yes of the drugs and
Okay.
just start with.
So you would reduce the tramadol?
Yes, yes.
Okay, and then would you add one of these antipsychotics?
Yes, yes, or benzodiazepams, maybe diazepams actually.
Okay. So do you ever use hydration to help somebody, like for example, if it's a drug induced delirium?
Yes, we do.
Yeah, you do. Okay. All right. So so it's important to recognize when a person is getting closer to the end of life. And I know that this is also very difficult depending on your culture and the people that you're working with. Like we talked about all the different aspects, like your religion, your economic class, your education. How much do people want to know about what's happening? It's important for us not to make assumptions that people don't want to know anything. So it's important to ask people. So I know in my context, a lot of people want to know how much time they have left or family members will want to know. So here's a little kind of, it's not for sure because I always say only God knows when the end is getting closer. But there are signs that we can see that can show us that the disease is moving and that things are progressing. So what I would usually say is if the person is changing every month, so that means they're weaker this month, they're eating less this month, they're able to do less for themselves this month, their pain might be worse, then it looks like they might have months. If it looks like they're changing every week, and so those would be the same areas that I would be looking at. So how much activity, how much are they sleeping, how much are they eating, how much are they able to do for themselves? If it looks like it's changing every week, then they might have weeks. If it looks like it's changing every day, then it looks like they might have days. So this is really difficult, especially if a patient or a family, and I know this is a very different context in Canada where doctors will tell patients that they have, 3 months, for example, and then they come to where I work because they actually don't have 3 months. And things are going very, very quickly. I will usually say to people, it looks like things are going quickly. I know it's very different in your context. I just had a patient who died last week who thought that he had 3 more months. And I could tell when I saw him that he probably had a few days. The reason why I could say that is because his change had come so quickly and so drastically, where he went from being able to pretty much taking care of himself, being able to get out of bed, to not being able to get out of bed, to sleeping all the time and not eating very much. So it's better, I think, in the situation that I work in because the people actually want to know, but I mean, you can't force people either. Apparently his family never believed that, but it's just a way to say it looks like things are happening quickly. So it looks like, I think we talked about that. I wish you had more time, but I'm worried that your time might not be as long as you hope it's going to be. So now we have another discussion time because we're going to talk about end of life. Is it possible for us to know that a patient is nearing end of life? We have talked about this before. So my second question is, do we need to tell the family that this is happening? So in the large group together, what are signs? And is it important for us? Do you think people there want to know or need to know? It sounds like you're having a very good discussion.
Yes, that's the discussion.
So I'm curious to know what your answers are. What do you think?
So please represent these
Okay, so we were discussing some of the few signs, and I think some of them are what we have been discussing from the beginning of this session, like hello, can you hear me?
I just need that person to have the microphone.
Okay. Can push it down. Okay. On top. I did. Meanwhile. Okay. So attention.
I don't hear,
Can you hear me now?
yes, I can hear you.
Okay, okay, okay. So we were discussing about some of these signs, yeah, and most of them, or some of them actually are what we or you have been telling us from the beginning of this session. So you could have situation where a person starts becoming having that altered state of consciousness, like the delirium. And also, you could also have other signs like difficulty in breathing. And I think some persons also added that most of them actually do know that they are getting close to um, the end of life, and then they start maybe saying all sorts of things, trying to bargain or say some words that you actually know that okay, yeah, this patient knows
Mhm.
what is. Then also you can also have state of unconsciousness where person maybe goes into coma. It happens in some cases too.
Mhm.
And the second question, how to break the bad is to okay.
Second question was, do people want to know? Do you think families want to know, or we should tell people what's happening?
Okay, yes, I think you should tell them what's happening. So that when it happens, they are not in so much shock.
Okay. Okay, good. So yeah, so you've got the oopsie. We've got the signs and symptoms that we were talking about. So the weakness, fatigue, um, taking less food, difficulty swallowing, the breathing changes, less urine output. And then we know in the very end that the breathing patterns really do change. And I think it is important. What I've noticed is that people will become actually quite anxious, families, when they see the breathing patterns changing, to just give reassurance to the family that this is actually what's happening right now is okay. I'm not sure also with the with the breathing, especially people sometimes will want that will be where people will actually call an ambulance sometimes. So it is important for us to be able to say this is normal. It's not necessarily distressing for that person, because this is just part of what's happening when the body is closing down. I often like to, when people stop eating and drinking, that's a really, really big thing here. I usually actually try to tell people that, when we're trying to help this person feel comfortable, when we're forcing them to eat and to drink and their body's not really needing the food and the drink anymore, it's actually making them less comfortable. And as well, we know that physiologically there are changes that happen in the body when somebody reaches that state, where the body actually releases hormones like oxytocin to make the person feel more comfortable. So although we all as believers will say that death and dying is part of the fall, God has created our bodies in such a way that the bodies do know what they're doing as it's time for them to move on. So to support somebody who's dying, like we talked about, it's important to identify that the patient is dying. I might still have a hard time using the word dying. And that's just maybe my personal problem. I might use words like the patient is moving on, but it is probably not a bad idea to use the word dying. I'm not sure in your context, but to at least that the family knows that the time is getting short. and that we're not leaving this person ever. I think that's something that we've talked about in palliative care as well, is that we never ever say it's too late and there's nothing we can do. There's always something we can do until the very end, because that person is still alive. Even if they're not talking and they're not responding, they're still a living person. And so we're still going to be making sure that we're with that person. This is where it helps to have chaplains again, who can actually be with people. And we talked about that as well, just the presence of being with somebody who's dying. I know sometimes family members are so sad, they don't want to deal with what's going on, so they might actually leave that person alone. But it is really important to recognize that that is still a human being, even though they might not be able to talk. And the research shows that hearing is one of the last senses to go. So although it's not easy to have a one-way conversation, we can still talk, and we can still encourage the family to talk. And then also anticipating problems before they arise and managing these symptoms. So one of the most difficult end of life symptoms for family members is the death rattle. I don't know if you call it the death rattle. This is a very common occurrence in people who are dying, and it's because the muscles in the throat are relaxing again. It's the body is starting to relax because the body is getting ready to close down. And so that noise that you hear of the person kind of like it's kind of like a gurgly sound. I'm sure you all know what it's like. You've all heard it. It's really, really, really hard for family members to listen to. And most of the time people will want suctioning, but suctioning is not always the answer. I think it's important in these situations to also explain to the family that what you're hearing is really hard. It's really difficult, but no, I know people will often say, oh, my loved one is drowning. That no, they're not actually having that sensation. But this is also a difficult. We can try to position the head. Often, even moving a patient from side to side can change that sound a little bit. Do you have any of these medications that you use when somebody has that end of life rattle? Do you have medications?
We have all are available.
Okay, so you have atropine drops.
Yes.
So do you use them?
Yes, we do.
Oh, okay.
Yeah.
Okay,
We use them when there is a need to enhance secretions.
okay, okay.
And
And do you,
one, like the
sorry,
last one, it is strictly under control.
right? Yeah. The glycopyrrolate. And we have another medication that we use. We do have glycopyrrolate as well. But I think the important thing for family members to know is that often once the person gets to that stage of their journey, we can try really hard to get rid of that sound, but we might not be able to get rid of it entirely. I don't know if you find that the atropine drops will actually get rid of the sound. Do you find it? Are the atropine drops pretty effective?
Yes, we use atropine drops.
Okay, okay, that's good.
We use
Okay.
both drops and also injectable.
Injectable, okay, okay, okay. Good to know. So some of the other considerations when somebody is getting closer to end of life is nutrition. So I'm just curious about this for you. Do people, how are people, do people usually get put on intravenous if they're not eating anymore? How do you decide if you're going to put somebody on an intravenous?
Usually when they're not eating or when they're not fully conscious, we use intravenous. Also when they are dehydrated as well.
Okay. But is every single person who comes into EGB who's dying and who is not eating and drinking anymore, does every single person get on an IV?
Yes, when there is an indication for that, yes.
Okay, so we don't use IV fluids in our hospice. When we know that people are getting very close to the end of life, often the IV fluids can cause a fluid overload. And so they can actually cause a person to become more uncomfortable than comfortable. But this is also a really a pretty big cultural thing, whether or not your culture would be okay with you not giving IV fluids for somebody who is very close to the end of life. We can give mouth care. So this is something we will do because usually people's mouths are quite dry, and we'll just clean the mouth out and make sure that we're keeping the mouth moistened. Often people are getting a catheter because, again, for us, the catheter depends on their comfort. So there are some people who refuse a catheter, and often well, if they're refusing it, we don't make them have a catheter. A catheter makes it easier for our care, and we don't have to move the person around as much. And so that is a comfort thing. We try to explain that. It's a comfort thing because when we're giving our care, we don't have to change them as often. But often if they're not eating or drinking, they don't really void that much. So a catheter might not be necessary. They might only go to the bathroom once a shift, for example. We can give, for fever, we can give cool cloths, or if we have Tylenol, or I think you have paracetamol there, suppositories, and just to make sure that we're giving education about common changes that happen at the end of life. And then there's spiritual and their cultural considerations. So I'm not sure in your situation as well, I'm imagining that there's a difference between what, let's say, somebody who comes in and is Muslim would want as somebody who's a Christian. Do you notice a difference with that? And I'm talking about when the person's actually died. Like I think that with that, oh yeah, are you going to give me an answer?
Yeah, in that setting, there is that religious inclination. So whether Muslims or Christians, all of them will be inclined to prayers. They want people to pray for them
Okay,
because they believe in the power of God.
okay,
So,
okay,
so most when the Muslims will request some prayers from a Christian.
okay,
Some when we want to go beyond the prayers, some might want to object
okay,
to this
okay,
Jesus.
okay. Okay, so that's good. So just to know that you know what the people there wish at the end. If they want to have their family, like are families allowed to be with the patients when the patients are dying? Do you allow the family to be at the bedside?
Yes, they are always at the bedside.
Okay, sounds good. Okay, so we're getting close to the end. So we've talked about the different symptoms today. And all of these symptoms that we've talked about, they influence quality of life. So we've talked about how shortness of breath, we've talked about anxiety and how anxiety can influence so many different things, and constipation. And we've talked about how important it is to understand what is the cause of the different symptoms that we're seeing. So to be little detectives and try to figure out what is this, and also the importance of using non-pharmacologic management because we can still help people a lot, even if we don't have the medications. And this is where just the whole teamwork and the whole spiritual and the social part of palliative care is so beautiful, because we know how important a chaplain or a social worker or a church member or a family is. It's not just about the medical system, but we are all a team, and we really need these people. And also, I think finding out the kind of resources that you have locally that are non-pharmacologic, so that are acceptable. So if we talked about ginger, and ginger is actually very good for nausea. So if that is something that you have there, then to use that. I know that sometimes people get this idea in their head that Western medicine is better, but it's actually not. So it's important for us to look at the things that are being used locally, that are being used correctly, and encourage that. And then if we need to escalate our pharmacologically therapy, that we do that, and that we don't allow people to be in their suffering. So if we are seeing a delirium, that we do treat that delirium, and then to consider the oral route, and then move to an IV if you can't. And I think that that's what you are doing in your hospital. And then also that we all recognize that prognosis is challenging. It is really difficult to know how much time a person has. But as we talked about, there are definitely signs that things are getting closer to the end. And it's important for us to, you know, let the family know that this is what's happening, and ourselves too, I think, to know how we can support each other and support the families. So for the end, do you have any questions or stories that you would like to share before we finish? Any questions?
No question.
Okay. All right. No stories, no questions. So thank you again for your attention. And hopefully, my hope is that these classes will stimulate you to talk amongst yourselves. Like I say, you're in a different context than I am. I actually do have a question, so I hope you don't mind me asking this question. And it has to do with your morgue. So one of the things that I found the most shocking about my visit to Egby was the number of bodies in the morgue. And I'm just wondering if someone can explain to me why there can be bodies in a morgue for so many years.
Well, I could say that that's challenging. We may not be able to give a straight answer, but I think one of the answers would be that. For me, it would have been appropriate. Why do we have so many bodies in the morgue for a long time, over a year? Well, for me, I may say some of the deceased, the families abandoned after the patient died. So sometimes because of money, the bill might be outrageous and they feel they cannot offset the bills, so they never show up.
Okay.
But times when we discover some of these corpse, especially if we are having challenges maintaining the morgue at that time, we may just seek like a court order for the hospital to bury the corpse so
Huh.
that we will not in the future. But I think that is one reason that I know that will make a corpse to stay for that long. It depends on family. So if the person is old, they may decide to be preparing for some more than a year. I said they will not carry the corpse. That is another issue.
Good afternoon, everyone. Actually, it depends on the family. Some might be planning for outrageous burial ceremony, and some they have to put a lot of things together before they can make a decision that this is when. And we have quite a number that the hospital have to reach out to for a legal backup for us to take an action and bury the corpse ourselves. So it's all depend, yeah.
Well, is a funeral very expensive?
He's an elderly patient. They want an elaborate ceremony. So lots of cows, barbecue, Yes, yes. It's expensive if it's an elderly person
Okay,
because they feel that if you don't do an elaborate party, you have not given a befitting burial to an elderly person. But
okay,
if it's a patient that dies, they just bury immediately. But once is a woman, a man, let's say 70 and above, it's a lot of money. Yeah, it calls for celebration for the family. So they need to gather a lot of money, savings to be able to, conduct that kind of burial ceremony.
Mm.
but are people not bothered or ashamed that their family member is still in the morgue after so many years?
The party is the most important because some families, there are some requirements, some traditional rites that they have to pay. And once they don't have money to do those rites, then they will not do the burial.
Okay,
They give a big cow to the family. They have to, do some kind of rituals like that. So traditional rites. And if they don't have money to do that, they will not go on to bury.
very interesting. Have you visited your morgue?
I don't.
Anyway, well, thank you so much. I was just curious because we went to see the morgue, and as I saw, I think I maybe saw 10 bodies in the morgue, and I just asked myself, how does palliative care help these kind of situations? Is there any way there's something that we could talk about or do, but maybe people don't have a problem with that. But I do know it costs the hospital a lot of money, right? To keep those people there. So, yeah. And I was just surprised because I think for Muslim people, especially, they need to be buried within a certain hour of dying. So I would make an assumption that most of the people in the morgue were not Muslim people. Is that correct?
So the
Yeah.
Muslims do immediate burial. Less than 48 hours, they must bury.
Yeah.
The only reason why it stops is because of maybe they are not able to settle the bills immediately. But once we know that as the hospital, we can release the corpse and then they come back to settle their bills.
Yeah. Okay. All right. Well, thank you very much. And I look forward to seeing you next week. We'll be talking about psychosocial. We have 2 modules left, and then the very last one is about self-care. If you have any questions, please put them in the WhatsApp, and we'll see what we can do. Thank you very much. Have a good afternoon.
You too. Bye-bye.
Bye.